So next, let's talk about the pharmacological effects of the antidepressants. So the number one effect is the blockade of the amine uptake. So drugs that block the norepinephrine transporters in the CNS. Okay, so they block the SERT. Okay, they block the NET. So example, the drugs like the tricyclic antidepressants, meprotilene, venlafaxine. So these drugs also inhibit the reuptake of norepinephrine at the nerve endings. Okay, so they also block the reuptake in nerve endings in the autonomic nervous system. Similarly, monoamine oxidase inhibitors, MAOIs, also will lead to increase in the norepinephrine in sympathetic nervous system terminals. And both of these can lead to the peripheral effects, peripheral autonomic, sympathomimetic effects. Even though that long term of usage of monoamine oxidase inhibitors can lead to a decrease in the blood pressure, but not in the long term. So we have the increase in the peripheral autonomic sympathomimetic effects. So we have the sympathomimetic effects. The next pharmacological effect of our antidepressants is sedation. So this is common in when we give tricyclic antidepressants and also some of the heterocyclic agents. Especially with mirtazapine and the serotonin 2 blockers, nefazodone, and also trazodone. So nefazodone and trazodone are the serotonin 2 blockers. Okay. So this drug is common. It's more commonly used for to get its sedative effects. So you can prescribe this in patients who are depressed and also they have sleeping issues. Okay, so they can be a sleeping aid. Okay, it helps with the sleep. Drugs such as the monoamine oxidase inhibitors, okay, MAOIs, SSRIs, bupropion. So these drugs are not suitable for sedation. So they are more likely to cause CNS stimulation. Okay. So when you are hoping to help someone trying to help someone to sleep, someone who's depressed, trying to help them to sleep. So these drugs are not suitable. Okay, they are less suitable. MAOIs, SSRIs, bupropion. So these are less suitable for getting patients to sleep. Okay. Okay, next we have the muscarinic receptor. So muscarinic receptor inhibition. So this is a third pharmacological effect of the antidepressants. So antagonism of the muscarinic receptors. This occurs with all tricyclic antidepressants. And we might also see atropine-like effects. With drugs such as nefazodone, amoxicillin, and meprotilene. For drugs like the other heterocyclics, so to help you with understanding this lecture, it's useful for you to take out a piece of paper and list down all the major categories of drugs. Okay, for example, you have TCAs, write it down, write down all the common TCAs, write down the monoamine oxidase inhibitors, write down the SSRIs, SNRIs, okay, and the other categories, and list down those drugs so that this, whenever I mention this, it will make more sense to you. Okay, make sure you write down those on a piece of paper, and if you want, you can paste it on the wall in your room. So we have the other heterocyclics, the SSRIs, and also bupropion. This can also lead to the atropine-like effects, but it's rather minimal, okay? So the effects are minimal. So the main atropine-like effects are with these drugs, okay? Nefazodone, oxipine, meprotilene. CVS effects is mostly with, again, tricyclics. Okay, that's why we try to avoid tricyclics nowadays, even though we still prescribe tricyclic antidepressants, but it's not the first line of drugs. So with tricyclics, we can get CVS effects, cardiovascular effects. For example, when you block the alpha receptor, you can get hypotension. And also you can also get depression of cardiac conduction. Okay, so your cardiac conduction is impaired, okay, when you give tricyclic antidepressants. So you can check in your books. So this is like a bit of work for you. What kind of cardiac conduction issues do we get with tricyclic antidepressants? So which interval is prolonged with tricyclic antidepressants? So this cardiac conduction issue may lead to arrhythmias. So this is not something that we like to have. Next category is the seizures or fits, because the threshold will get lowered when we give TCAs and also monoamine oxidase inhibitors. So that this is another negative side of the TCAs and the MAOIs. So when you give, if the patients take TCAs or MAOIs higher than the prescribed dose, so they have a higher likelihood of getting seizures. And drugs like metprotyline, okay, SSRIs, and metprotylines also, in overdose can lead to seizures. So next, let's talk about the clinical uses of antidepressants. Number one is obviously major depressive disorders. So this is the primary, major depression is the primary clinical indication for giving antidepressants. So patients will vary in their responsiveness to the agents. Generally, we tend to give the newer drugs, okay? Newer drugs. So sometimes people, how do you remember the newer drugs? Okay, the difficult way is to remember the newer drugs, okay? To remember the newer drugs, to remember the newer drugs. So you remember that the newer drugs are SSRIs, SNRIs, the serotonin blockers, serotonin antagonists, and also some of the heterocyclics. So then only you remember the older ones. So that's one way. But the easy way is, of course, to remember the older ones, okay? If they are just the TCAs and the MAOIs. So if you remember the older ones, then you can remember that the rest are the newer ones, okay? So the newer ones, they have less issues, okay, in overdose. That's why we tend to favor the newer ones, because these newer ones have more tolerable side effects, okay? So their side effects are better, okay? So they have better side effect profile and also better safety profile in overdose, okay? So when you overdose on these drugs, they're not so bad as compared to when you OD on the older drugs. In terms of effectiveness, they are quite comparable, whether the newer one or the older ones. As an alternative agent, okay, the tricyclic drugs, they are most useful in patients with psychomotor retardation, patients with sleep issues, patients with appetite issues, and also patients with weight loss. So sleep, appetite, weight, psychomotor retardation, and you want to prescribe something other than the newer drugs due to some reason, so consider TCAs. MAOIs as an alternative drug. So they are most useful in patients with significant anxiety, patients with phobic features. So they have phobias, whatever phobia it is. Okay, claustrophobia, okay, fear of confined spaces, agoraphobia, fear of going out in the public, etc. So many phobias. And then and also hypochondriasis. So patients who are hypochondriacs, say, you can consider as an alternative to give monoamine oxidase inhibitors. SSRIs, they may reduce your appetite, okay, which can be desirable sometimes. And maybe not desirable in some other conditions, in some other situations. So patients might lose their weight during the first 6 to 12 months. 6 to 12 months, they have reduction in their weight. And there are concerns, okay, there are concerns about previously, I'm not sure whether it's still a concern currently to check. So we have concerns about SSRIs and SNRIs and the newer heterocyclics. Okay, this one, the newer heterocyclics, they were thought to cause increase in suicide risk in children and adolescents. So other clinical uses other than for the depression, TCAs, okay, tricyclic antidepressants are also used for treatment of bipolar affective disorders, for acute panic attacks, phobic disorders, D/O is disorders, okay? Enuresis. So enuresis is problems with patients who, especially children, who they tend to urinate, okay, they are not able to control the urine at night, especially. And then ADHD, and also chronic pain states. So that's why TCAs continue to have its own use. Okay, so it's still used, even though we try to reduce the usage in psychiatry, but it's still used in medicine, for example, because of it's used to treat chronic pain states. SNRIs, such as duloxetine and venlafaxine, so they're effective in patients with neuropathic pain, for example, due to diabetes or after amputation, and also fibromyalgia. So fibromyalgia is a complex disease that we tend to diagnose by exclusion. Okay, you can check out on the website on the internet. How do we diagnose fibromyalgia? Okay, tend to occur more in ladies. Okay, more in ladies. Besides the SNRIs, we also have the drug duloxetine. that is approved for pain due to diabetic nephropathy. Okay, one of the TCAs, which is clomipramine, and then the SSRIs. So they are used, they are effective in the treatment of obsessive compulsive disorders. SSRIs are also used for patients with GAD, okay, generalized anxiety disorders, panic attacks, social phobias, okay. So they have phobias of attending social gatherings, okay, kanduris, all that, okay. Public meetings, and also PTSD. Yes, PTSD. Okay, example, veterans, war veterans, people who have been raped, people who have been robbed, okay, people who have gone through very, very bad happenings in life. And then bulimia, and also premenstrual, dysphoric disorders. And they might also be useful in alcohol dependence. For nicotine dependence, usually we use bupropion, okay? So chronic smokers, okay, smokers, bupropion, okay? So SSRI is a really, is a drug with many, many users, okay? So try to remember some of these. Next, let's discuss the toxicity and drug interactions of the antidepressants. So for TCAs, they are largely predictable from their known pharmacodynamic profiles. So we can have sedation, they become very sleepy, they become very tired, lassitude, fatigue, okay, occasionally they can be confused, sympathomimetic effects, so they have increased heart rate, tachycardia, they become agitated, they sweat, okay, they lose sleep, insomnia, because they are so active, their brain is active, so it's difficult for them to fall asleep. And then we have the atropine-like effects. So you can go back to our previous videos and look at this, what does atropine-like effects refer to. And they did develop orthostatic hypotension. So the blood pressure drops when they change posture. So they might faint or they might fall. They also have ECG abnormalities, okay? Abnormalities on the electrocardiogram. So when we do an ECG, look at their heart rhythm, so we can see abnormalities on the ECG. Can be significant, can be not. And then can develop heart issues like cardiomyopathies. So this is one of the things that we really don't really like about TCAs, okay, cardiomyopathies. And then tremors, okay, they become trembling, tremors. They have paresthesia, okay, issues with their nerve sensation. Some will develop weight gain, okay, they gain weight, become more obese. And overdosage is quite dangerous, can be lethal, okay. So manifestations of the overdose include agitation, delirium. So delirium, they become delirious. They are not orientated to the time, place, and person. They don't know who they are talking to. They don't know whether it's day or night. They don't know where they are. Maybe they are in the hospital, but they think they are somewhere in, okay, Disneyland or somewhere. They have neuromuscular. They might develop neuromuscular irritability. They might develop fits, coma. They can develop their respiration becomes depressed, okay? So their respiratory rate goes down. The circulation collapses. Circulation collapse. Okay, blood pressure all goes down, heart rate goes down. They develop fever, hyperpyrexia. Okay, they develop cardiac conduction issues. So they can get severe arrhythmias. So to remember this, usually they use the 3 C's, mnemonic, coma, convulsions, and cardio toxicity, okay? Coma, convulsions, coma, convulsions, and cardio toxicity, okay? So with regards to the interactions, so beware of the additive depression of the CNS with other central depressing agents, okay? So there are, if you give other drugs that can depress the central nervous system, for example, alcohol, barbiturates, benzodiazepines, opioids, okay? Opioids like fentanyl, heroin, pethidine, oxycodone, okay? All of those drugs that are CNS depressants, central depressants can further, okay, depress the central nervous system in patients who are already on tricyclic antidepressants. Next is the SSRI, okay? So drugs like fluoxetine and other SSRIs may cause nausea, okay? They can cause headache, okay? So it can be severe sometimes for some patients. That's why we need to counsel them, tell them prior to giving them this drug that they might develop this and they should consult you or come back if they have issues with the drug. Okay, anxiety, agitation, sleep issues, okay, they cannot sleep, insomnia, sexual dysfunction. So if they become jittery, okay, they become jittery, you can, you might give them low doses of benzodiazepines. They can take low dose benzodiazepines. Okay, if they become jittery. They might develop extrapyramidal effects early in treatment. So they might develop akathisia. Okay, they cannot sit still. They are always they are restless. Okay, they have movement disorders, dyskinesias. They might develop dystonic reactions. Okay, some of the muscles like they are contracting out of control. If there is a very severe overdosage, you might develop fits, convulsions. For the heart, drugs like citalopram can cause QT prolongation. Okay. So withdrawal symptoms, sudden withdrawal of SSRIs can lead to nausea, dizziness, anxiety, tremor, and also palpitations. So that's toxicity. Okay, now we talk about drug interactions of SSRIs. Some of the SSRIs are inhibitors. Okay, they are inhibitors of the cytochrome P450, CYP450 isoenzymes. And so when they are inhibitors of CYP450, this can cause increased activity, okay, of certain drugs. It can cause increased activity of drugs like the TCAs, tricyclic antidepressants. They can cause increase in activity of warfarin. Okay. And so in terms of the SSRIs, citalopram causes fewer drug interactions compared to the other ones. Okay, so that's one good thing about citalopram compared to the other ones. So if someone is going to be on many drugs, okay, because of his concurrent diseases, he needs to be on many other medications. So you might want to consider giving citalopram, okay, even though this drug is more expensive than the other SSRIs. So serotonin syndrome, so this is a life-threatening condition. So patients develop severe muscle rigidity. They might develop myoclonus. They have fever. They develop cardiovascular instability. So the cardiovascular comes haywire. Their blood pressure, their heart rate goes up and down, becomes unstable. And they also develop marked CNS stimulatory effects. So including they might develop fits. So drugs that have been accused, okay, or implicated in causing serotonin syndrome when concurrently used with SSRIs include MAOIs, TCAs, dextromethorphan, meperidine. Okay, meperidine is an opioid. Okay, and the herbal drug St. John's wort, and also possibly recreational drugs such as ecstasy, MDMA. To treat serotonin syndrome, drugs that can be used include the anti-seizure drugs, okay, drugs that are used for seizures, for example, benzodiazepines, etc. Muscle relaxants, and the serotonin blockers, such as cyproheptadine, okay, have been used for treatment of serotonin syndrome. Next, SNRIs, serotonin 2 blockers, and also heterocyclic drugs. Okay, we're talking about the toxicity of these drugs. So mirtazapine, it causes weight gain. It's quite sedating. So also trazodone, okay, mirtazapine and trazodone. These drugs cause increased weight and sedating, so that they are not good for especially female teenagers. Drugs like amoxapine, epropylene, mirtazapine, trazodone. These drugs can cause autonomic effects. Okay, effects on the blood pressure and heart rate. And amoxapine, since that this drug is also a T2 blocker, okay? So that might lead to akathisia. Can develop Parkinsonism, and also the amenorrhea galactorrhea syndrome, okay? So you stop your menses. So these ones are, of course, are more in, we have talked about this more in the antipsychotics, okay? So don't worry too much about this, because you might get confused. I don't want you to be confused. So this one you can not think too much about it. Bupropion can lead to anxiety, unfortunately, agitation. They become giddy, dizziness. They develop dry mouth. Okay. They have increased psychosis. Okay. And at high doses, they might develop seizures. So these antidepressants, of course, we don't try to give them if it's not indicated. Okay, so they can cause all sorts of problems, but of course, we have to always weigh the benefit versus the possible adverse effects. Okay, because of course, it's better for a patient to be a little bit anxious or have a little bit of dizziness or a dry mouth rather than them being too depressed and then they commit suicide. Okay, so it's still better than. So we have to look at the bigger picture always. Venlafaxine, it has shown to to cause a dose-dependent increase in the blood pressure. And it also has CNS stimulant effects. Similar to SSRIs. So venlafaxine is not a drug that you want to prescribe if you want the patient to sleep, okay, fall asleep. And this drug is related, it's associated with bad withdrawal symptoms, okay? Bad withdrawals, even after missing a single dose. With regards to the drug interactions part, so this is all about adverse effects, okay? Toxicity. With regards to the drug interactions, venlafaxine and also efazodone, okay? Efazodone. So these drugs are both inhibitors of CYP450. So efazodone, when it blocks the CYP3A4, okay, CYP3A4, so this will enhance the drugs effects of carbamazepine, okay, which is an anti-epileptic. It can enhance the clozapine, which is an antipsychotic, and the statins, okay, the HMG CoA reductase inhibitors, and also the tricyclic antidepressants, okay. So beware of prescribing efazodone together with the other drugs because of the potential adverse and potential drug interactions that can happen. So MAOIs, it can cause hypertensive reactions, okay? Because of the indirect acting sympathomimetic effects. And then they can have hypothermia, CNS stimulation, causing agitations, and also convulsions, fits. So we might develop a hypertensive crisis in patients who take MAOIs and they are also taking food that contains high concentration of the indirect sympathomimetic theremin. Okay, you can look up what is the indirect sympathomimetic theremin, like cheese, etc. So in the absence of indirect sympathomimetics, MAOIs typically lower the blood pressure. And overdosage of MAOIs can lead to shock. Okay. Shock. So the blood pressure drops very severely. They develop hypothermia. They develop fits, seizures. And when MAOIs are given together with the SSRIs, it has previously caused serotonin syndrome. So MAOIs are the least important of the antidepressants, okay? So I think that's all for now. I might post more videos later on. Not sure whether you people have the time since that you have the exam coming soon. Okay, try to revise and try to memorize the main antidepressants, okay? The main categories and the main name of drugs in those categories. Okay, so do not dwell too much on the adverse effects and all this that are too sometimes quite difficult. Try to remember some of the clinical uses or indications of the drug. Okay, I'll see you people tomorrow for the class.